Ladies and gentlemen, friends, colleagues, good morning and welcome. Today is Friday, the 31st October 2025, and this is our final webinar for the Rack Diabetes Challenge 2025. Our topic, diabetes and foot care. And to my general understanding, about 20 to 30% of diabetics will require, well, I would imagine all diabetics would require foot care, but about 20 to 30% will require surgical foot care. And again, to my understanding, a large percentage of surgery, of general surgery, is also related to the diabetic foot. Now, today we have an extremely qualified and experienced surgeon who will be talking on this subject. I had to refer to several texts to understand the range of Dr. Niranjan Ravichandran's qualifications and certifications. I had to understand the difference between an MS and a DNB, for example. Well, it's a matter of choice. Sometimes you like apples and sometimes you like oranges. But Dr. Ravichandran has both of them. Well, and much more. Dr. Niranjan is a specialist in surgery in the RAC hospital. He completed his MBBS, his MS in general surgery. He is a member of the Royal College of Surgeons in Edinburgh, and I mustn't forget that he is a member of the Association of Laparoscopic Surgeons of Great Britain and Ireland. That talks about the breadth of his certification. He has worked in India and in the University Hospital, Coventry, Warwickshire, in the United Kingdoms. I notice that he has experience and likes teaching, and he teaches, amongst other things, that complex subject of surgical skills and clinical medicine. He has numerous research papers and publications, and his specialization includes many words that I cannot pronounce. Laparoscopic, I've got that, and then cholecystectomy. I'm sure Dr. Ravi will say that word more correctly than I can, but I've got it right when I say laparoscopic appendectomy and hernia and hemorrhoids and the entire spectrum of abdominal surgery. Ladies and gentlemen, I know I'm wasting your time, so I will hand this over to Dr. Niranjan Ravichandran.
Thank you for the wonderful introduction. Good morning, everyone. I just need some help. I'm not sure how do I share the PowerPoint slides with you.
Doc, you have been given sharing rights, so you can share it.
How do I do that?
There is a button on the bottom, up arrow with a box, square box with up arrow.
1 second. Where? Sorry? Can you
On
share?
the bottom?
Yeah,
Yeah, share. Once you click the share, it will open two options. One is screen and one is, yeah, perfect.
Okay. Am I audible?
Yeah, clear.
Good morning, everyone. Today I'm going to talk about diabetic foot, its complications, and how do we manage it, and most importantly, how to prevent it. How do we go to the next? Oh, yeah. So, did you know that 1 in 4 patients with diabetes develop diabetic foot ulcer in their lifetime? So, this explains the magnitude of this problem, and this explains why we need to be careful in taking care of the foot, especially in patients with diabetes. So what are we going to go through in this presentation? We'll start with a brief introduction about what is diabetic foot and what causes diabetic foot, how to assess, how to investigate treatment and prevention. A diabetic ulcer is a condition where patients with diabetes develop a small breach in the epithelium, which is in the skin, which can worsen to deep ulcers involving the layers of the foot like subcutaneous tissues, muscles, and can involve the bone also. When it involves the bone, when it becomes dead, it can only lead to surgical intervention. So the most important thing with diabetic foot ulcer is do not neglect, do not deny, meet the doctor. Otherwise, what can happen? Even small ulcers, small pimples can produce infection. It can produce pus in the foot, infection in the bone. It can spread upwards to the leg and to other parts of the body. And if not treated, it can lead to gangrene. What is gangrene? Gangrene is a condition where there is no blood flow to the area. Gangrene is a condition where you need to chop the area which is dead, which can be just a toe, which can be foot, or which can be leg also. So you need to be aware of all these things and you need to make sure that you prevent them. Almost 30 to 40% of patients with diabetes mellitus they develop peripheral vascular disease, which means these patients can lead to blockage of vessels. Diabetes in itself is a high risk factor for blockage of vessels. I'm not talking about the vessels in the foot. This is something which can happen proximally, the vessels in the thigh, the big ones. Yeah. So diabetes plays a role in all the vessel blockages. As small as a rise in 1% of HbA1c, the normal is less than 6. Just a small increase from 6 to 7 and not controlled for a long time can increase the risk of peripheral vascular disease. When you have an ulcer, suppose you get a trauma and you have an ulcer, you know that you have an ulcer. But the problem with diabetes is you may not know because the nerves are also damaged. So you may not have pain. And that is one of the most common causes of worsening of diabetic foot ulcers. What are the risk factors for developing diabetic foot ulcers? Of course, high glucose levels, uncontrolled glucose levels, smoking, and alcohol, and also obesity, and associated problems like cardiac problems, kidney, and liver pathology. What it does, basically in cardiac, kidney, and liver pathology, water gets collected in the body, especially in the foot. When there is excess water in the body, the skin becomes damaged. When there is skin damage, ulcer develops. In normal people without diabetes, this ulcer heals. But in people with diabetes, these ulcers do not heal easily, and that is when all problems occur. Now coming to pathogenesis. What is pathogenesis? How does diabetic foot, how does diabetes cause diabetic foot ulcers? It's multifactorial, which means that there are lots of theories and lots of factors involved in forming an ulcer, starting from neuropathy. As I told you, when you have neuropathy, which means that the nerves do not work, you do not know whether you had a trauma or not. easily patients with diabetes come to us. Many patients tell us, I did not even know how it started. I just noticed this today. So because of loss of nerves, you will not experience pain. And this is one of the commonest causes for diabetic foot ulcers. Vasculopathy, as I told you before. Usually, diabetes affects small vessels of the foot, very tiny vessels. You may have good blood supply elsewhere, but these tiny vessels are affected by diabetes. Immune dysfunction, as you all know, when patients with diabetes they have low immunity. So the response from the body to clear the infection is less with patients with diabetes and infection. So uncontrolled sugars can lead to all of the above. This is a wonderful picture depicting what all I said before. So what is motor neuropathy? What happens with patients in diabetes is the bone alignment and the bone is slightly deformed. So usually the pressure is distributed between the toes and just behind the toes and heel. What happens if there is a slight deformity? Pressure alignment differs. When there is high pressure on one side and not on the other side, they might develop ulcers. On top of it, if you do not know whether you have pain or not, then you will not know when there is a formation of ulcer. And autonomic neuropathy. This is basically between sympathetic nervous system and parasympathetic nervous system. There is some misalignment which can cause dry skin. Again, dry skin can cause ulcers and skin breakdown. If the skin breakdown from basically motor neuropathy, sensory and autonomic neuropathy, if the skin breaks down, on top of it there is an infection or less blood supply, this can lead to ischemia. Ultimately, this will lead to amputations, which we do not want to happen. That's why the entire presentation is about. So, vasculopathy, as in what is atherosclerosis? Atherosclerosis is formation of plaques inside the blood vessel. Blood vessel is important for supplying blood, oxygen. You all know about that. So atherosclerosis is a pattern where, atherosclerosis is where you have blocks inside the vessels so that it gets blocked eventually. What happens with diabetes patients is these blocks are formed early. These blocks are formed aggressively all over the body. Why is it important? Because other patients who do not have diabetes, there is something called distal revascularization, where if there is an impending block, the body's coping mechanism is where small other vessels will develop for revascularization. Okay, this is called distal runoff. For patients with diabetes, it is so aggressive that by the time the distal revascularization happens, the wound gets affected. If you know about osteomyelitis is infection of bone. Why is it important? Usually, osteomyelitis happens by bloodstream infection, but in diabetes, osteomyelitis is by contagious spreads. What does that mean? If there is a wound and if there is infection and it slowly spreads from the skin to the subcutaneous tissues, to the muscles, tendons, and then it affects the bone. At least 1 in 5 patients with diabetic foot ulcers will have amputations. And this can be detected by a simple X-ray if it's not obviously visible, but we think that he might have osteomyelitis, then CTs and MRIs will help in diagnosing it. Why is it important? If we don't diagnose osteomyelitis early, this might lead into amputations because patients with osteomyelitis need long-term antibiotic management. If we do not give that, then the chance of amputation increases fourfold. With diabetic foot, what is the commonest site of osteomyelitis? As I told you, where there is pressure. So when you put your foot down, you see that the pressure distribution is between the forefoot, involving the toes and the bones just behind the toes, and the heel. So the forefoot is the most commonest site of both diabetic ulcer and osteomyelitis. Hindfoot involves 10% of patients. 10% of patients involved will get hindfoot osteomyelitis. And the commonest bone affected is the first and the fifth metatarsal. This is the bone which is just behind the toes. And calcaneum. Calcaneum is the bone which supports the heel. So, so as you know, when you place the foot, the pressure points are at the heel and the toes. So these bones are at the heel and the toes. So what it means that pressure is also an important factor in the in the uh, in developing diabetic foot ulcers. This is an X-ray of a patient. If you see, this is the ulcer here. It might appear superficial, but if you see here, the patient has an osteomyelitis. So this patient needs long-term antibiotics. Otherwise, this ulcer will not heal. There are two classifications for diabetic foot ulcers. The first one is Magic-Wagner classification, where the wound is classified based on the depth of ulcer and the presence of bone infection and gangrene, with 0 being intact skin. 1 is a superficial ulcer. 2 is a deep ulcer to the bone, tendon, and ligaments. 3 is osteomyelitis. 4, localized gangrene, where maybe one toe is involved. Extensive gangrene involves the whole foot, may involve the leg also. As you can see in this photo, it's normal skin, maybe slight redness over here. And this is a superficial ulcer involving the foot. This is relatively superficial, not very deep, but still it's in the gray zone. These are all pictures of gangrene where this foot is dead. So this patient might need amputation. This is extensive gangrene of the foot. This type of gangrene is called wet gangrene, where you see cyanotic foot with infection. This is dry gangrene. This foot is gone. The other classification is Texas classification. It's simple and easier to follow. It is based on infection and gangrene. If there is no infection, no gangrene, it's stage A. If it's infection, it's stage B. If it's ischemia, it's stage C. And if you have both infection and ischemia, it's stage D. So treatment-wise, it's a multidisciplinary approach. What do you mean by multidisciplinary approach? Basically, basically it involves multiple doctors, surgeons, and endocrinologists, who are the sugar doctors. They are responsible for controlling sugars either by giving tablets or insulin. And microbiologists. They are the ones who culture the bacteria from the womb and tell us which antibiotics can be given to this specific person, which antibiotics are more effective to this specific person, so that we can heal the wound faster. Careful evaluation of diabetic foot. What it means is, it means assessment of the foot ulcer by measuring the size and type of ulcer. Is it going to gangrene, or can this be treated just by dressings? So this requires experience, and this requires methodological analysis. Investigations. This is a vast topic. Basically, with investigations, the commonest thing I just mentioned, the commonest things that we do. The commonest thing that we do is to measure septic markers, where we see how bad the infection is, to see if there's any osteomyelitis or not by doing X-ray or MRI. Yeah, and we also check other organs, because, as I told you, diabetes affects small vessels. These small vessels are in the foot, around the kidney, and eyes. These are the three organs which are commonly affected in diabetes. So all three organs has to be thoroughly investigated. Once the diabetic foot ulcer is investigated, the next thing is to inform the patient what is the current status, to control his sugar levels. This is, how do I say, this is a vicious cycle. Basically, with diabetic foot, what happens when there is an infection? When there is an infection, sugar levels go up. When the sugar levels go up, infection goes up. So it's a vicious cycle. So unless we clear the infection, the sugar levels will not come down. However, if the sugar levels are more than 400, it's mandatory to control or reduce the sugar levels to considerable levels like 200 or something like that, and then proceed with treatment. Treatment involves wound care. The ideal motto, the end goal is to obtain closure as early as possible. As I said, with investigations, we start with an X-ray. Almost always we can find the involvement of bones on X-ray, but if we cannot find osteomyelitis, and if as clinicians and surgeons, if we strongly suspect that osteomyelitis is a possibility, then we go ahead with MRI or CT scan. MRI is advantageous because it not only detects osteomyelitis, it also gives us information about soft tissues like muscles and tendons, whether they are involved or not, because debridement, if need be, has to be done till there is a good blood supply. Arterial Dopplers, these are investigations to assess big vessels. Like in the lower limb, there are two big vessels, basically femoral and popliteal artery. Femoral artery is the artery of the hip. Popliteal artery is the artery of the knee. And there are distal small arteries like dorsalis, but in all those things. Anyways, so the need for arterial Doppler is, as we told earlier, that there is a possibility of vascular disease in patients with diabetes. We all know that diabetes involves small vessels, right? But there is a possibility that these patients can also have proximal vessel problems. If there is a blockage in the popliteal, the knee vessel or the hip vessel, by doing arterial Doppler, we can rule out if these vessels are involved. Why is it important? If these vessels are also involved, by clearing plaques in these vessels, the blood supply will improve to the foot, which again improves the chances of ulcer healing. As I told you, septic markers are important like procalcitonin, CRP, WBC, presepsin. It not only gives us the severity of infection, it also helps us assess if the infection is improving or not. We cannot keep on doing X-rays and MRIs to every patient. So we do septic markers once in 2 days, every day, to see if the infection is improving. If the septic markers are reducing, then the infection is improving, as simple as that. And diabetic workup, of course. We check the sugar levels frequently. Initially, when they get admitted, we check their HbA1c, which gives us a good measure of the sugar levels for the past 3 months. When it comes to assessment of ulcers, as I told you before, so basically, the location of the ulcer is the most important parameter. As I told you before, 4-foot ulcers are okay, can be managed easily. Also, if there is a 4-foot ulcer, if we go for amputation, it's only going to be toe amputation. Yeah. But if the location is at the heel of the foot, then the chance of going into a below knee amputation is very high. So the location of ulcer is very important. The size of the ulcer, to see if the ulcer will heal on its own or whether the ulcer might need a flap cover, which we will discuss later on in this presentation. Color of the wound. Color of the wound is very important, whether there is pus in it or slough in it. There's only two colors when it comes to whether it's yellow three, in fact, whether it's yellow, whether it's red, or it's black. Black needs debridement surgically or other measures. Yellow needs minimal, we can do it, minimal debridement, which can be done in OPD basis. A red color wound is a good wound. Um, an exudate. What is an exudate? Exudate is the type of discharge which is coming from the wound. So when we open a wound, which is the breast, we see the gauze, the color of the gauze. If it's red, it's good. If it's brownish or if it's foul smelling, then it's bad. So the type of discharge. When it comes to type of discharge, there are multiple types of discharge. Basically, whether it's thin. A thin dishwater pus involves severe infection, which happens in necrotizing soft tissue infections. And if it's a bloody discharge, it is good. Amount, how much the volume of pus, whether he needs a drainage or whether the patient can be managed only by dressing. As we discussed earlier, color, red and yellow pus. Consistency, as I told you, a dishwater thin pus is more dangerous than thick pus. And adherence to the ulcer bed, which means where is the bed? Is it as deep as the bone, or is it just involving subcutaneous tissues, which is the second layer of the foot, or is it going into the muscles? All these are important. On the left side of the slide, you see a relatively superficial ulcer, and it's pink to red, so we expect good closure in this patient. Whereas on the right side of the wound, you see it's involving the heel. On the left side of the wound, sorry, on the left side of the wound, it's involving the arch, and it's not on the forefoot or the heel. So there is less pressure on this wound, so we expect a faster healing. Whereas this ulcer is at the heel. Any heel ulcer always carries a high chance of an amputation at the level of the foot. I'm sorry, at the level of the leg. So heel ulcers are very dangerous and has to be treated meticulously. So any ulcer which needs debridement will involve at least two stages. First stage will be our goal is to basically debride all the dead tissues till we see blood. And even though we do this, eventually the gangrene can progress. This is the nature of diabetic foot. So most of the ulcers require one or two stages, one or two debridements. Sometimes it can be three. As I told you, the role of the microbiologist we take a small swab from the wound and send it to the lab. They do cultures and they do antibiotic sensitivities and give us information as to what type of antibiotic is suited for this particular patient. Based on that information, we give patients antibiotics. Mostly, we start with IV antibiotics for a few days, and if the wound is improving, then we convert it to oral antibiotics and discharge them. If the wound is deep and if the wound needs meticulous approach, we keep the patients as inpatients. So there are lots of non-operative methods which we can make the wound heal faster by modifying their shoes, which involves the whole idea is to avoid pressure when they walk. Okay, which can be made by a cast or modification of the shoes or something called an offloading dressing. So this is what we do. Basically, see if you see the ulcer is on the forefoot. So what we do, we cover the ulcer with the dressing, and then we cut gauze pieces in a way with multiple layers. You can see there are multiple layers of gauze piece placed, and we do a dressing so that this ulcer is not on the dependent part. So when they walk, this ulcer is not having any pressure. When the ulcer has pressure, the chance of wound healing is delayed. It can worsen the wound also. So this is the basis of floating dressing. So with regards to surgical debridement, there are With regards to debridement, there are two types: surgical and enzymatic. Surgical debridement is commonly followed across the world. Enzymatic debridements, they are not followed in most centers. Only teaching hospitals, and very rarely some of the hospitals they follow these enzymatic dressings for study purposes, which involves all these enzymes which they apply on the wound to see if the slough gets debrided on its own. Um, some hospitals tried honey. Some centers even went to an extent they tried worms. They put worms on the wound so that the worms will eat all the slough to make the wound clean. There are various medicated dressings for wounds. What we saw here is a polyurethane film. Yeah, as the wound is dry, these polyurethane films can be placed. This is our patient. This patient is recently admitted under our care. So this patient had a small pimple, and he neglected it, and his HbA1c was 13. The normal is below 6. His HbA1c is 13, which means that for the past 3 months at least, he has neglected his sugar levels. So what started as a pimple and what should have been treated early and simply has extended as a gangrene to the foot. So he needed debridement. Excuse me, please. He needed debridement. So we debrided it. It involved the whole of subcutaneous tissue. The entire subcutaneous tissue was necrotic. Luckily, his muscles were okay and his bone was okay. And this is the picture post debridement. So we debride till we see blood on all the edges. So these are the types of wound dressings. The commonest wound dressings the commonest wound dressings for diabetic foods are alginate, polyurethane foams, and hydrocolloid. These are thick dressings which kind of they are sponge in nature, in simple terms, which can absorb the exudate, which can absorb the pus and all, and also keeps a moist environment. So these are commonly used in diabetic foods. And these polyurethane films are used for dry wounds, like this wound. This is a polyurethane film. And saline gauze is applied for dry gangrene, like this one. Okay, so these are alginate dressings. These are like foams, basically. They absorb the exudate, yeah, and keep the wound moist. These are polyurethane foams. See, they are thick, so they can absorb more um, pus and exudates from the wound. The hydrocolloid dressings. This is an interesting new methodology. I would say new because it's 10 years. So there's something called negative pressure wound therapy. In other words, in simpler words, it's called vacuum assisted closure, where we apply suction to the wound so that the exudate and the pus is all absorbed. And this type of treatment, vacuum assisted closure or negative pressure wound therapy, has a lot of advantages. We started doing it basically 15, 13 years back. So what it does is it applies suction to the wound. So macroscopically, as in when you see that the exudates are absorbed, it brings the wound together close. Microscopically, what it does, it reduces the bacterial count, and it promotes new vessel formation, which is called neoangiogenesis. This new vessel formation, which helps in wound closure, as early as possible. When are they contraindicated? They are contraindicated in untreated osteomyelitis, wounds which are gangrenous, and wounds which has an exposed vessel on top. For instance, if there is an ulcer at the back of the knee vessel, which is called popliteal artery, which is if it is exposed, if vacuum assisted closure is contraindicated because of the pressure, the vessel can rupture. The next method of mechanical dressing is hyperbaric oxygen therapy. This is a closed chamber. Um, this is a closed chamber, as you can see, where the ulcer with the foot is placed, and they give hyperbaric 100% oxygen for some time so that the wound gets improved oxygen. It prevents hypoxia, where improved oxygen and improved blood supply, which is these um, techniques are available only in certain hospitals, but this technique is available everywhere. Most of the hospitals they have negative pressure wound therapy. In fact, it can be made in a simple manner also. This is a suction device, and this is the foam which has been placed on the patient on the ulcer, and this is the suction tube which is placed on top of the foam so that it constantly absorbs the exudate, helps in new vessel formation, reduces swelling, edema, brings the wound closer. Um, I still remember 15 years back when we started this vacuum assisted closure, we used to take a small Gamgee pad, which is, I was in India, so which is just less than 5 rupees. We use something called a Riles tube, which is 15, 20 rupees. We place the tube inside the foam pad, and this cling film, we use the cling film across the foot so that there is no leakage. This needs complete closure where should not be any leakage. We cling film across the Gamgee pad and the Riles tube, and we connect the suction to the Riles tube so that it's like a modified negative pressure wound therapy. So this can be achieved through simpler forms. It doesn't need any expensive management. Do you remember patient A, whom we debrided? So he's now on vacuum assisted closure, negative pressure wound therapy. This is the mission. The pressure should be between 100 and 125. So he's doing well. His wound is improving. Hopefully, he doesn't go into amputation because this wound or the ulcer is in the heel of the foot. So once the wound fills up, we need to, as we said, the ultimate and the end goal is to achieve closure. So for wounds which do not have any pressure, like the ventral aspect of the foot, um, we can do something called skin grafts. These grafts are taken from the thigh and can be placed on top of the wound. But when it comes to the plantar aspect, where pressure is high when we walk, these grafts do not survive. So we need to do a flap cover. So four flaps can be done by a rotation flap, where we can cut some tissues from the other aspect of the foot and rotate it to cover these ulcers and stitch it. One of the commonest flaps that we do is a rhomboid flap for 4-foot ulcers. For heel ulcers, rotation flaps can be done depending upon the size. If it's small, yes. If it's a large ulcer, then rotation flaps may not help. And as I said, that if the wound doesn't heal on its own, and if the wound is extensive, there's a possibility that they might end up having amputation. So these are the types of amputation that were tried, and it's a case of a non-salvageable wound. For wounds which are involving just the toes, what we do is an amputation called race amputation, where we remove the toe and the head of the bone. And as shown in this picture, the incision which we place is classically called a tennis racket incision. And then the toe is removed at this point, and this bone is the proximal bone to the toe, which is called metatarsal bone. The head of the metatarsal bone is removed so that we can achieve closure and there won't be any pressure. These are other types of amputations where they did. And of these amputations, the most common type is this amputation, where we cut the bone in the middle of the foot, and this is called transmetatarsal. I mean, a presentation, please. Anyway, I'm sorry. Where was it? Where were it? Oh, yeah. So these are other amputations. Of these amputations, the most common amputation is a forefoot amputation, which is called transmetatarsal amputation. These amputations are all were all tried, but the prognosis in terms of stability is better when it comes to transmetatarsal amputation than race amputation. If the infection involves the heel, or if there is ascending cellulitis, which means the goes into the leg, then the next level of amputation is a below-knee amputation, where we measure 10 to 12 centimeters from the knee, and then we chop the bone with some extra tissue on the back, and we close this wound here. Why is this important? This amputation gives you good results in terms of prosthesis. There are two types of prosthesis which are famous, and that's why these two amputations are widely practiced when it comes to infections involving the foot and thigh. Above knee amputation and below knee amputation. These are the various amputations which were tried by various people all over the world. However, there are only 4 types which are prevalent, which are common. The first one is the race amputation, which we discussed. Second one is transmetatarsal amputation. Third is below knee, and the fourth one is above knee amputation. So you see, below knee and above knee amputation, the prosthesis is almost as equivalent as a foot. Look at the range of movement this guy has. So these amputations are widely practiced mainly because of the prosthesis and stability. Now we come to the most important part of the presentation, how to prevent. As you all know, prevention is better than cure. So in general, denial and negligence is the most important reason for diabetic foot ulcer. Many people I know who have diabetes try to deny, try to avoid medications. So acceptance is the first part of treatment. So there are various preventive measures. The most important thing is lifestyle modification, where make sure that you control your diet, do walking, and make sure that you lose weight. Sugar control is very important. So when you're diabetic, make sure that your sugars are under control. And HbA1c monitoring every 3 months is mandatory. Even though you feel that you are under control, you may not know unless you test it by blood test with sugar monitoring and HbA1c monitoring. HbA1c monitoring every 3 months is must for everyone with diabetes. Blood pressure control, because as we all know, blood pressure, cholesterol, they all play a big part in vasculopathy. They all play a big part in vessel blockage. With just diabetes, the blood supply to the foot is compromised. So we don't want hypertension or cholesterol to make it worse. Stopping smoking is the most important step which I would advise for patients with diabetes and who smoke. This is a wonderful picture which helps us to take our to take foot care seriously. Every patient with diabetes should wash their feet with lukewarm water and soap, and then dry the foot, apply moisturizer, check your feet every day, every night, just to see if there is any cut or any sore, because you may not know whether you have a cut or not. We discussed about this earlier due to neuropathy. Yeah. And cutting toenails, very important aspect. Do not go to the edge of the toenail. Do not try to cut the nail to the edge. Leave it at a reasonable length. Yeah. Try to wear footwear at home, because even if you get hit against any furniture, footwear will bear most of the pressure and your foot will be safe. Yeah, when you wear footwear outside, make sure it is not tight and don't walk outdoor or indoor without footwear. Take home messages, clean your foot, make sure it's moist, take care of your foot, see your inspect your foot every day to see if there's any cut or any sore. As we discussed earlier, avoid walking barefoot. Proper fitting shoes are important. Loose is okay, but never tight. Don't cut, don't do any interventions on your own, like just don't cut any corns or callus on your own. Make sure you apply moisturizers regularly. As we already discussed, no smoking, exercise. Exercise, it should not have high impact. You should light walking. Walking every day is very important, but at the same time, running with people with diabetes, you have to be careful. Yeah. Swimming is a good exercise. It's an isotonic exercise. Cycling is a good exercise, which helps in basically reduce weight. And when you reduce weight, your insulin resistance reduces and your sugar control will become better. Examine your foot regularly, and I cannot emphasize the importance of controlling your sugar levels. Don't be, don't neglect your wounds. Consult a doctor even if you have small wounds. Thank you. Any questions? Any doubts?
Dr. Niranjan, I don't quite know whether it is you who should say thank you to us or we who should say thank you to you. Now, that was an extremely informative and interesting presentation. Uh, you know, the early part of the presentation was in many ways frightening, but I am so delighted with the pictures and the brief discussion that you had on prosthesis, meaning that even after amputating the foot or amputating the leg, as the case may be, it was replaced almost to human efficiency, and uh, that is an extremely relieving thought for individuals who might have an extreme form of gangrene. Uh, so, 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 thank you for giving us the good news that in spite of a bad situation, there are surgical and other alternatives. That is one. The second, I recall in many news channels, they uh, frequently mention that please be informed that some of the pictures may be disturbing. And I can assure you that many of the pictures that you showed were remarkable, remarkable to the extent that it gave us a complete indication of the depth of the problem. Thank you so much for going through the uh, difficulty of selecting appropriate pictures. Thank you so much. Thank you so much.
Thank you. Thank you.
This reminds me very much of a time in which I had an automobile accident and I had skin grafts, etc., etc. But I was told by Dr. Wilku prior to the start of this event, the doctor of this webinar, that Dr. Niranjan said, Doc, keep it brief. I have my surgery to attend to after this. So, therefore, I will keep it brief and leave the questions now to Dr. Wilku. Dr. Wilku, sir, keep it brief. Our good doctor has his
Yeah.
surgery to attend to.
Yeah, thank you, Professor Kennedy, and thank you, Dr. Niranjan, for a wonderful session. He have given a lot of clear things. Still, there are few questions. I think you have already answered, but I will take those questions as it goes. I'll take only 3 questions which have been posted in the chat. Anyhow, I'll take your help to reply the mails. First question was asked by Jinsi. What signs a diabetic patient look to prevent ulcers? You have already mentioned. So, what are the signs the patient should be looking to prevent ulcer?
Basically, as I said, inspection of foot care is an everyday process. Okay, so foot has to be examined every day by the patient, self-examination of foot. As I told you, with diabetes, what happens is the loss of sensation is an important factor. If you notice, as a normal patient, when you go near furniture, you have this thing from the brain, the response from the brain, where you tend to avoid the furniture and walk. This is a normal thing for every patient. But in patients with diabetes, you lose that. So they tend to get hit quite often. So these are things that you need to see. Yeah. In fact, my father is a diabetic. And when I went to my home on a vacation from here, I examined his foot and he had an ulcer, which he did not know. He never knew he had an ulcer. So examination of foot is the most important thing the patient has to do.
Yeah, regular they have to check on it. Another question Professor himself has asked: is foot massage helpful for a diabetic patient for to improve foot circulation?
I have no idea. Sorry about that.
No, actually, it must be, but depending on the condition of your leg.
You're the right person to answer that question.
No, true. Definitely, foot massages are good, but if you don't have any ulcer, then, or if you don't have any bluishness, swelling, or if you have a tender skin, then you should avoid. First, consult a doctor, and then only you can go for a massage. Don't go at random. Another question is very interesting from Raj Kumar. Is diabetic foot and gangrene same thing? Or also can diabetic ulcer come after the surgery?
Of course. See, basically, first of all, first things first. Diabetic foot ulcer is the initial presentation. Gangrene is the end presentation. Yeah. So, for instance, if there is a patient with diabetic foot ulcer on the great toe, and which ended up being gangrene, we removed the great toe. Okay, not a big deal. Still can walk, everything is fine. There is no guarantee that he'll not develop ulcer on the little toe, because these are the 2 points, the great toe and the little toe. These are the 2 points of pressure. There is no guarantee that he will not develop on the little toe. There is no guarantee that he will not develop on the heel. So the most important parameter is sugar control. So if sugar control is achieved, if the sugars are under normal levels, then the chances of re-ulceration is less likely. Whenever there is neglected sugar control, there is a chance of infection. Whenever there is an infection, as I said, this is a vicious cycle. It just goes on like that.
Yeah, true.
So,
And
to answer
you
the
were
question
mentioning about
simply,
prevention.
to answer the question simply, yes is the answer. He can develop ulcers again.
Yeah, and can it result a foot amputation? You have already said if it is not properly managed, gangrene can result into amputation. Yeah. And third thing, you were talking about some prevention at the last takeaway message.
Yes.
So there is very common myth people, those who are diabetic or those who have high blood pressure, they used to walk barefoot on the grass. So for diabetic patients, especially, it is advised not to walk barefoot. And
Shows
I think,
outdoors. Well,
yeah, true, true. I think we should close for now. Professor, over to you.
Niranjan, thank you so much, sir. Please
thank you.
go right
Thank you
ahead and
for having me
complete
here.
the rest of your very important duties. Go right
Thank
ahead.
you.
Thank you
Thank you
so
for having
much.
me here. Thank
Okay.
you. All the best.
For the rest of our audience, thank you also so much for attending this lecture. It was so informative. It was so informative. I mentioned earlier in the day that this was our last lecture for our challenge this year. On the 8th and 9th, we have the final HbA1c lifestyle evaluation. 8th and 9th would be this Saturday and Sunday. Right? We look forward to having as many of you as possible in RAC Hospital for this screening, and for the rest of you who are virtual participants, well, go to your clinics and have these screenings done. 8th and 9th is the final day. Uh, uh, the final thank you to the speaker, the audience, and to the backup team of IT and Arabian Wellness, Dr. Wilku, everyone involved. Thank you so much and have a good day. Looking forward to seeing you all on the 8th and 9th for the final HbA1c evaluation in RAC Hospital.